Simon is a professor of entrepreneurship and the head of the Global Economics and Management Group here at the MIT Sloan School of Management. He's authored over 300 high-impact papers in just the last decade. And he's also written several books. And I always like to mention his recent book with Professor Jonathan Gruber, Jumpstarting America. We will put this information in chat for you. As I think in the spirit of MIT, it offers a solution, not more analysis on how we can begin to fix our economically divided nation here in the US. And I think we're seeing these things happen on a global scale. I encourage everyone to read it. I love the approach of that he and Jonathan took to how do we fix this, not what's causing it. Anyway, when the pandemic started, Simon joined forces with Professor Retsev-Levy and formed the COVID Policy Alliance. And I will let him tell you about this and the incredible progress they have made. We'll also stop midway for questions, so please ask him in Q&A. Thank you. And Simon?
I really appreciate sharing the ALP, bringing me together with my colleagues to push us to have these more detailed conversations. I should also say, with regard to my colleagues, that I'm standing on the shoulders of some amazing efforts by incredible people, including Retsev-Levy, already mentioned by Sherry, and Kate Kellogg, who's been working tirelessly with Massachusetts Senior Care Association. I'll talk about the work we're doing on nursing homes. But I should also, and a number of other really prominent faculty mentioned on my slides, I should also issue a disclaimer that none of these people are responsible for what I'm about to lay before you. These are my own personal views, and I'm here to explain a new and important direction of research and application, operational applications that we're now pursuing. Now, I think it is reasonably self-evident that behind every really big systemic crisis lies an enormous failure. I've worked on crises for 30 years. It's been a major preoccupation of my professional career. I worked around the world on these problems. I was the chief economist at the International Monetary Fund in 2007, 2008. And, you know, as you can imagine, I worked a lot on finance, financial structure, financial regulation during that period and subsequently. But this problem is at its core, I think, something that's a little bit removed from finance. It's about public health. And more specifically, I think it's reasonable to ask, without pointing any fingers or getting into any version of the blame game, what was the failure at the heart, or what is the failure at the heart of the sequence of events that have brought us to our current situation, which, let's face it, is an unmitigated global disaster from which we are only now beginning, potentially, and I think potentially is something I took away from Dimitri's presentation too, potentially beginning to extricate ourselves. Well, just from the point of view of the United States, which again, you've seen the global picture from Dimitri, this is just one sliver, but it's an important sliver for everyone on this call. What failed? Well, I think I will submit to you, and I'll make the argument and hopefully back it up, that the core of our collective public sector and honestly private sector failure is public health surveillance. We failed to see what was coming at us, the timing and the pace and the nature of it. And so a dramatic example is we now believe that in February of this year, there were tens of thousands of cases of COVID-19 in the United States. How many of those did we detect using virus testing and symptom follow-up and all the vast technology at our disposal, including in the hospital systems? 23 cases in 5 US cities. 23 cases. This was an enormously consequential failure. So Dimitri already made this point, and this is building on what he said. But if, again, we look through the lens of New York City and imagine that they could have seen the train that was heading their way 1 week earlier, then they either could have, I mean, depending on what your view of the policies is, you might say, well, they could have done a complete lockdown, or maybe they could just have warned people to back off, to wear masks, to be careful. That, I think, has been well established, and Dimitri emphasized, would have saved a lot of lives. And I would suggest actually could have put us on a course to save lives and have much less economic destruction and devastation, which is also has major effects on people's lives and impact on their health. So did we have a technology available to us in February 2020 that could have provided a better warning to New York City and everyone else about what was coming and the kinds of measures needed to be taken? And the answer, I'm afraid, I have to tell you, is yes. We had that technology. It's a very well established technology and could have been deployed. It was not in place, and it therefore would have been a scramble to put it in place in February, but that's part of where I'm heading with this discussion. The technology is serology. It's antibody testing. And what I'm going to do in the second part of these opening remarks is explain a little bit more detail why this is now reliable and how we can deploy it and who needs to be involved or who is involved actually in pushing that forward. And in fact, you can think of this as a complement to Dimitri's point about, Dimitri was a lot about analytics and data analytics, obviously, and Dimitri cares a lot about data and is very good at getting the data together. We're very much in this project about generating new data from antibody testing that can be fed into various models, including those of Dimitri and other people. And I'm going to be arguing that is scalable and inexpensive and will add a great deal of value based on what we understand currently. But before we get there, let us launch our first polls. So here we have poll number one. How often do you wear a mask outside the home currently? So your choices are all the time, only when I know I'll be within 6 feet of others, or indoors, sometimes, or never. And let me ask you to respond to this poll now. We have a lot of people who are wearing masks at least sometimes, and it's an interesting question exactly what the right mask policy is. And so this is, I think, a very interesting and important point about masks. And well, let me actually come on before we come on to masks, and while you're contemplating that, let me actually make one other point, which is I think somewhat dramatic and you know, in perhaps even unpleasant. And I'm sorry to have to bring this up, but I do think it's of first order importance, because our failure to anticipate what was coming and our failure to control the infection rates, and Dimitri's model that laid out for you in some detail, had catastrophic consequences, particularly for some demographics. And what I've been doing for the past 3 months with Retsev Levy, with Kate Kellogg and Vivek Farias, Valerie Karplus, Yashing Huang, and other members of the faculty at Sloan is working very hard to bring better solutions to residents of nursing homes. And you know, frankly, this was an enormously mad scramble at the beginning to try and help them access testing, to find better personal protective equipment. We had to arrange imports from China, actually, at certain key moments, because, you know, frankly, the government wasn't getting the job done. We also helped mobilize infection control resources, and Kate Kellogg's worked a lot on bringing additional workers, trained workers, appropriately trained workers into the mix. We also helped build a pilot surveillance program. I can talk to you more about that. And we helped to persuade, I would call this advocacy through action, our approach. We helped to persuade the state to provide an additional $130 million of funding, although we continue to discuss with the state how to use that funding and ways in which strategy can be properly adapted and applied to the nursing home context. There is still however, and unfortunately, extreme danger as we head into, you know, whatever you want to call it, second wave, third wave, continuation of the first wave, particularly because when new residents move into the nursing homes, and as people die, very sadly, they're replaced by new residents who are mostly susceptible, not at all immune to the virus. And there is a real risk of a sort of repeat forest fire process. So we need to build much better public health radar to do what exactly? Well, this is why I asked you the question about masks, because the evidence is quite clear. Not all of it, I will agree, has been published in the top journals yet, but it's a lot of this is underway. And this is a nice graphic and part of a survey pulled together by Pekko Hossoy, who's Associate Dean of Engineering at MIT, showing that the available evidence supports wearing reusable, washable cotton masks, well-made cotton masks, two-ply masks with at least a 600 thread count, will give you a great deal of protection, particularly when both parties wear masks. And outside of the healthcare context, where, of course, N95 masks are preferred. It seems, on the basis of this available evidence, that everyone who can wear a mask should be wearing a mask as much as possible, particularly when they cannot maintain social distance from each other, which is what your poll results were showing, but which, of course, would not be the poll results if we asked this question. It was answered honestly in some other parts of the United States. And let me ask the poll launchers to launch the second poll, please, which is about your own actions. So how often do you expect to be in your office or other place of work in September 2020 per week? And let's, to be fair, let's compare this with the same time last year. So do you think you're going to be in your office and therefore around people? And this is I'm clearly trying to get at, a crude but perhaps reasonable metric for social distance from other people. Oops, put the poll back. There we go. So same as 2019 is relatively small. Never is extremely interesting, and perhaps that's a little bit encouraging in the sense that you're engaging in remote work. And I would guess that the people on this Zoom call, the fact you have access to Zoom and the fact you listen to the ILP and read their emails suggests that you're inclined to be able to be remote working. So that's actually a positive. Half the time is I think, what we'll see from a lot of people. So that means we can't all maintain as much distance as we would like, perhaps. And waiting to hear what the schools will say and will do is important. And I think that some of you know that Massachusetts is supposed to produce its school guidelines at 11 o'clock this morning. So what can we do to try and make ourselves safer, and what could be the basis of this public health radar system that I'm talking about? Well, it's really interesting that a lot of people and organizations, including organizations with a lot of money, well-resourced organizations, are pushing really hard on some version of virus testing. And I'm not opposed to that, but I would point out that virus testing for fast-moving viruses like this one is generally considered to be a pretty unreliable way to track prevalence and to anticipate where outbreaks are going to be. That was a very good question to Dimitri just now on what happens next. At the top of the top figure on the right here in red, we have people as the rows, and the columns are periods of time, so roughly a week. And you see the virus or a virus moving through the population, jumping between people, and a lot of people becoming infected. But at any one point in time, even actually, if you look at those columns carefully, even quite late in the outbreak, depending on when you sample people, you might not get a lot of positives. In the second panel, that's on virus, PCR virus testing, the standard that we have right now. In the lower column, we have serology testing, which is looking for antibodies. Now, I fully understand there are questions and perhaps even controversies about the extent to which antibodies are informative currently, with regard to immunity or the degree of protection that you have against reinfection and so on. But it's certainly true that antibodies are a good measure and a remarkably reliable signal of who has been infected. I mean, let me just take one example from our work. One of my colleagues is helping a large company in a particular state monitor the antibody level of their employees on a monthly basis. And what she found is that this particular company had 3% seroprevalence antibodies in the blood in 1 month, and then 15% the next month. Well, that's an outbreak. I mean, that is not even an issue you have to debate for a long time. From 3% seroprevalence to 15%, you need to go into whatever mode you have, and we'll pull whatever levers you have to deal with an outbreak, which could be partial shutdown of operations. It could be some form of quarantine. It could be a lot more virus testing. I think this is exactly what we're missing in general, is a general serosurveillance antibody monitoring system around the country. And I would say to everyone who's planning to test their employees for virus once or twice a week, you need to focus on compliance issues, because people may be willing to do that initially, but after a month, particularly a month of low prevalence, I don't think college campuses or school communities or cities or large companies are going to be getting very high compliance. It's going to be an extremely difficult problem. And even if you do have reasonable compliance, how informative is that signal by itself? I mean, in general, just speaking to people I'm engaged with, nowhere near as informative as they currently think. Now, there are obviously questions about serology tests, and there have been press reports along the lines of suggesting that serology tests are inaccurate. Those press reports are not speaking about the current assays, which are, for example, this one is developed by Galit Alter at the Ragon Institute, which is part of the MGH health complex, and is also connected with MIT. This is a highly accurate test, and the accuracy is similar in some of the commercially available tests that are running in labs around the country right now. So serology is absolutely ready for its time in the limelight, if you like. And it's unfortunate that some of our press colleagues have not fully caught up with that. It's also unfortunate that the CDC has not clarified sufficiently this point, but have no fear, we are very deeply engaged with them in that conversation.
Simon, can you hear me?
I think the big goal here, and maybe we can call it the Holy Grail, so we pursue it forever and don't quite get there, but in the pursuit, we will learn a lot, and we will generate a lot of useful data, and data will be picked up by Dimitri and other people, I would sincerely hope. Global weather forecasting for viruses, I think, is what should be on the agenda. What are we missing? What do we need in order to build this? Well, I think there's sort of three pieces. One is you need serology at low cost with high quality. And low cost means below $20. I think we're aiming to drive it down to a marginal cost below $10, depending on who we work with and the kinds of scale we can bring in from the private sector. We might even get lower than that. We are recommending dried blood spot technology. It's much cheaper. It's super easy to collect. The test kit is literally a lancet, a piece of filter paper, a Band-Aid, and an envelope to send the result to the lab. It's all self collection at home, and it's very scalable. Of course, this should be public health infrastructure. You know, when I'm asked by people in the funding world why this is needed, I actually generally turn around and say to them, why haven't you built this before? I mean, look, I have worked on economics, I've worked on politics, I've worked on public health issues around the world for a long time. I've not worked on pandemics, and these global health problems have not been the focus of my activities. I will readily concede that, but you know, I'm a data guy coming at this problem through the pandemic like the rest of us. And my question to the established incumbents is, how is it possible you didn't build this before? It's cheap, it's reliable, and it's without this data, I'm seriously doubting our ability to understand where we're going next, let alone predict the next or anticipate or see the next coronavirus coming. The established clinical diagnostic labs are terrific, but this has not been their business model. Sure, federal, state, government, international organizations should do this. And we can have a conversation about the political economy. I mean, I've been to the White House with this. I've been to the state capitals. I've talked to people in the international community. It is not going to happen unless we do it for ourselves. I mean, that's just the reality. And I think that this is the key piece. I mean, there's a lot of good data out there, some of which much of it Dimitri was showing you. But unless you know who's been infected, unless you have an accurate measure of infections, and serology will give you that. Virus testing will not give you that, not consistently, not over time. Without that data, I am seriously doubting, whether even our most sophisticated tools and all the other data that we have, including on human mobility and so on, whether that will get us to where we need to go. This is the team that is building this. This is the team I'm involved with. I mean, there's lots of other people around the country. We can talk about that, and we're building many alliances and partnerships. I think the good news about this pandemic is it's put people on convergent tracks, and we love to work with people and build those relationships. Galit Alter is our chief scientist. She's a brilliant immunologist at the Ragon Institute, and she's the mind behind making sure we have the most accurate serology tests that can be deployed in labs and can be scaled up. And we have 2 third-party labs that are already coming up to speed, and they'll be available for dried blood spot testing by early August at the very latest. And so commend that to you, and we can absolutely happy to connect you with those people. And we also have Michael Minna, who is a very unusual chap. He is an immunologist and a clinical pathologist, MD, and an epidemiologist. not sure there are too many other people in the world with that combination of skills. And he is the mind behind the high throughput lab that we're putting together to really demonstrate to people how this can be done and to drive the costs down, because that's important. And here's the technology that we propose to use to change the data landscape here to create the basis of global weather forecasts for viruses, and hopefully to begin to change what's imaginable and what's possible around pathogens as a whole. This is a dried blood spot card, and I will concede to my friends who worry about good jobs that we're going to use a lot of robots. It's a highly automated lab, very simple sample collection, very simple logistics, and a highly automated lab process in order to analyze, and a lot of very up-to-date immunology, and an exciting frontier, which Boston is obviously one of the hubs, not the only hub, but one of the hubs for scientific research around the immunology and around what exactly can you determine from one dry blood spot. To be clear, we are never going to do blood chemistry. You cannot do reliable blood chemistry from a dry blood spot. I don't think you ever will be able to, but you can look at antibodies. And from antibodies, you can understand a lot about pathogens and a lot about where pathogens are in people. And when we add this data on a massive scale to what we already have and what people like Dimitri have already built, I think we then have a much more powerful set of tools for combating not just this pandemic and the next pandemic, but actually all of the pathogens that currently plague and are scourges on humanity. So let me pause there. Let me put the go back. Let me drop my slides. And Sherry, let's see if there are any specific questions there. And then I am going to have a few more things to say, and then we'll go to the general Q&A with Dimitri.
One of the questions I had for you was regarding again, similar to the question that we had with Dimitri, is regarding the second wave and what you guys see in that regard, because I think that's one of the popular questions we see.
Yeah, so I think Dimitri put it very well, and I totally agree with him, which is, we're still very much in this first wave, right? It's floods around the world. I mean, what we're seeing right now in Arizona, Texas, potentially Florida, potentially Carolinas, is that the first wave, or is that the beginning of the second wave? I mean, I think it's somewhat semantic, right? I completely agree with Dimitri. It's not going away. We were hoping for a bit of a break a northern hemisphere break in the summer, Sherry. But I think what we hadn't sufficiently figured is the intent is when it gets really hot and people go inside to air-conditioned spaces, that's actually what generally drives coronavirus impact higher in, say, in Boston in the winter, right? It's going indoors, it's being closer to each other. So I think we're in the midst of one continuous massive wave, Sherry. I think perhaps New England might think of itself as getting ready for the second wave, but the rest of the country is still in the middle of it.
And as you begin to see across the country, I mean, I don't know how often it's happening, but people are rebelling. I mean, about wearing masks, about all of this. I mean, how long are we going to be able to, in your mind, control the public to not just saying, we'll give up and deal with, we're not going to be affected, we'll give up and deal with whatever comes. I mean, that seems like it's happening across at least the US. I don't know about the world.
Yeah, I think it's a US feature, Sherry. It's not a feature in East Asia, for example. I think people have a different mental model. Look, it's extremely unfortunate, and you should bring in some of our great behavioral experts from Sloan to talk about why it's happened. But it's obviously, the basic fact is pretty simple, which is we've gone from this complete lockdown to wanton disregard for being safe, right? And that's why I asked the question about masks, and also the question about going back to work. It seems to me that the audience we've got here is actually quite mindful of the continued transmission of the disease and quite concerned about spreading infection. So, what I would say, I mean, I think part of the point of the weather forecast idea is that even Americans who are deeply skeptical of government, when you tell them a tornado's on the ground or a hurricane's heading their way or a snowstorm is about to completely, make road travel dangerous, most people will pay attention to those forecasts and they will move to protect themselves and their families. And that self-preservation instinct, which is natural with all of us, will help the community a great deal. See, right now, I don't think we're in a place where people are listening to those forecasts, in part because they're not sufficiently granular, right? What is the virus? So IBM, as many of you may know, now owns the Weather Channel. I'm trying to persuade them that in every hour's weather forecast, they should include 5 minutes virus forecast. Where is the virus in the country? Where is the virus going next, right? Just like you look at the radar to see where the tornadoes could be, or let's do the same thing for viruses, and let's elevate that discussion, and let's show people the data, right? Because people want to, if I just say, if Simon says the virus is coming or not coming, I mean, what does that mean? Or Dimitri shows you his forecast. So the good thing about that is you can evaluate ex post, okay, is Dimitri on target or not for this or that geography? I think we need that level of transparency, but in a much more public, digestible way. And it needs to be on our phones every morning. We're saying, what is the, I mean, let's do the pathogen forecast, right? If you do the dry blood spot technology properly, and I'll talk about this in a minute, you can add lots of other pathogens into your surveillance system. Where's Lyme disease today? Where's seasonal flu? Where is anything else that's affecting people? We can get that all from pathogens. We can get that all from dry blood spots, and we can use that to inform each other. Think of it like Waze for viruses. Do you use Waze, Sherry, when you're driving?
I know it. I don't drive anymore. Very little. I take public transport.
Some people who used to drive, Sherry, used it to see where the traffic obstacles were, and some people used it to spot where the police were with their radar guns. I would never do that personally, right? Anyway, so think of Waze for viruses, where we show each other in an anonymized way with differential privacy, so you can't reconstruct who it is, but we show each other what we know, what's in our blood, right? And we therefore notify each other about where the pathogens are, and we therefore know I should avoid these bus routes. I should not go to work today. Let's have MIT take the week off or go to remote mode because we know the risks are more intense. And I think it's basically, think of Dimitri's forecast, but at a level of granularity that would be, 100 or 1,000 times more drilled down, right? Which, given the data, I'm sure he can do that for you, probably in 24 hours. So that it would tell you where the pathogens are relative to your own daily concerns and considerations. I think that's the powerful piece here.
One of the questions I had that I wanted to ask you both about, and I still will, is this whole idea of contact tracing, because it sounds like you're doing it, but without actual contact tracing. Is that correct? Because there's a lot of controversy over that. How many people are going to download the app? All of that. So what you just proposed using contact tracing, or is this using another methodology in terms of
we're
granular or very granular ways tracking?
So we're proposing to add widespread use of serology, antibody testing, Sherry, which to be clear, there are antibody tests that are being done, but they're not fed into a public health surveillance system right now. Most clinical diagnostic companies are not set up to do that. It's not their job, right? And most public health departments are a long way from having the infrastructure necessary to do that. So you think of it as weather buoys. It's weather buoys or measurements of barometric pressure that we have around the world that feed into a data system that you then use for forecasting storms such as hurricanes. That's what we need, and that's what we're missing. Contact tracing is important when you have an outbreak, when you spot some infections. You use you go back through the contacts and you try to encourage people to either get tested or go into quarantine, or get tested and then go into quarantine if the tests are positive. So that's a complement, and that's a piece of how and some countries like Korea use that very effectively, and we're still debating and discussing how effective it'll be in the US. This is not an either or, Sherry. These are complementary elements of a data system. Well, what we're talking about is a data system, and from which you can then get models, like Dimitri's modeling team, and then from that you then derive actions like we contact trace in the following way, right? So they're all integrated pieces of a system. We need the whole system. Right? So just a couple more pieces, and then we can talk with Dimitri, which I'm looking forward to that. Which is in addition. So what am I doing, and what's my team doing? So we're very focused on serology. We feel this is a key part of the data we want to bring. We're also working very actively on an immediate problem, which was flagged by some of you in the poll results, which is getting back to school safely. So what we know about school children is that they may transmit the virus. Now, it is almost certainly the case that very, very few of them will become seriously ill. Many of them may be asymptomatic when they transmit. There's also evidence from Denmark that suggests that children under the age of 10 will not actually transmit. And if we can become confident of that, that's a pretty important piece of evidence. But certainly, if we're talking about middle school and high school, this is a very serious risk. Now, there are many schools grappling with this problem right now. There's obviously many parents who want this to go right, and that we have an effort led by Alan Geller from Harvard School of Public Health that is building what I would call a form of expert network focused on back to school. What do we know from established science, from experience in places like MIT, which are putting a lot of resources into understanding how to operate classrooms safely. Masks are obviously a very key piece. Wearing a mask whenever you can, and certainly for middle school and high school students, masking is super important. Bus transportation is a key piece. There's a system here that I think every parent and everybody who's been through the American school system knows intuitively, and we are bringing in at least lessons learned from hospitals, nursing homes, other higher education and prior public health interventions, and we're doing this quickly. We're doing it in a transparent way. We'd be happy to have other people involved in this. Bloomberg Harvard City Leadership Initiative is doing fantastic work in this space already, and we are basically trying to help them share ideas and information and also figure out what works. And I think that the monitoring the different approaches and trying to understand the problem, because there's a lot of pieces moving at the same time and in the same way. But if you're interested or your school district is interested in more information, we can connect you to the City Leadership Initiative, and they will be managing that interface, and we're providing them with content and any and all pieces that can be useful. I think there are three things that really come through as super important, just to sort of make this concrete. One is understanding ventilation. So masks are the number one issue that we should all be aware of, and wear masks whenever we're around anybody else, and have kids at appropriate ages wear masks as much as they can. I mean, let's be honest, the compliance is going to be less than perfect, and we have to recognize that. Ventilation, understanding the different kinds of ventilation status of rooms. It's about air change, it's about airflow. Lydia Bareva is the world's leading expert on this at MIT. She's done fantastic work on the fluid dynamics of droplets, and she's bringing that expertise to assess ventilation in our various spaces at MIT. Actually, starting with the Sloan School, I definitely get an assist on mobilizing Lydia and persuading Sloan administrators we should do this. So I think you could think of this as being probably a three-tier system where it'll be poorly ventilated, okay ventilation, and the best available ventilation. And then you can think about how long you want different children to be in various spaces. And same thing's true for college campuses, by the way. If you sit with a mask in a poorly ventilated space, let's say a movie theater or a big classroom, for a long period of time with infected people, you are going to get infected. Okay? The masks are not, they're not magic. They are reducing your exposure, and they're giving you a longer window of time when you can be around infected people without yourself picking up the infection. But I think we can at least get a grip on measuring ventilation. That's something all facilities, people everywhere, hopefully are going to get engaged in and understand some of the heuristics that we develop. Second point is busing and transportation. You know, clearly you have to run many public school systems with buses. You can't increase the number of buses dramatically, or perhaps you actually can't increase them at all in the short term. And so then the question is, how do you move buses more quickly and more effectively through transportation systems? And Kathy Wu at MIT has some very concrete actionable items there for buses of all kinds, including public transportation in general, but we're also working to apply those for school buses. Ventilation and masks on buses are also going to be very important. And then there's some really important, I think, frontier work that's been done at MIT by Eric Arm's lab, ALM, and there's a commercial spin-out called BioBot, which tests wastewater and monitors wastewater for the presence of COVID-19. Now, I don't think that's a technology that everyone can afford or that would necessarily be appropriate or easy to deploy at a school district level. But I think it definitely along the lines of multiple layers of protection. And it does seem to us to be a very good idea for college dorms, for example. And we'd be happy to connect you with those people, with Eric and his team, who are absolutely excellent. I think more broadly, the agenda here, and this will be my last point before we go to the discussion with Dimitri. Actually, I'll put up one more slide after this. Is finding public-private partnerships. I mean, we can go back after the fact and write books, and I'll probably write a book, and Dimitri hopefully will write a book, and maybe you'll all write a book about what happened, why, and who bears what kind of responsibility. I think, frankly, to get us through what we're in now and to get us to a better place, at least get us to where the vaccine becomes scaled up and available widely, and perhaps 12 months is realistic in terms of deployment and so on. I think we're going to need some very innovative public-private partnerships. This is about sharing data. We're working on that. It's about bringing some of the amazing tools and ideas from human mobility analytics, which are pretty sophisticated, bringing that into public health, where I think there's a real thirst for that. Public health information systems have a lot of the data that people want to see and need to see, but they're not, that data that does not flow in a easy, seamless, actionable way onto the desks or the phones of school administrators and superintendents, for example. So we can make that better. It's not super complicated, but requires some effort, and it requires a lot of people to agree. And I think there's an obvious set of sensitivities when we talk about sharing data, particularly healthcare data. Who's going to see it? How could those systems get hacked? Who might, how might data leak out inappropriately? And I think the answer to that, I mean, this is a very, very important problem. I can't emphasize enough its centrality to everything that we propose going forward. But I do think private computation, or otherwise known as encrypted distributed computation, where we don't need access to your data in any decrypted way. You can even run your own algorithms on your own data, and don't even have to show us those algorithms. But if we can extract the signal, you show us the signal from the healthcare monitoring data, or maybe it's other data from the population that you're responsible for example, your employees, and then we pool those signals across a geography. For example, use the fact that a lot of colleges are doing extensive testing in the greater Boston area, and use that to build a better surveillance system or data layer, which people can build various kinds of models on, that will help protect everyone in greater Boston area or in Massachusetts or more broadly, including the K through 12 schools that are honestly not going to have anything like the money available for testing resources that you have at MIT or Harvard or Boston University, all of which are going to have robust testing programs. So I think, and I'm going to pull us, I'm always going to pull us back to what I regard as the key performance indicator, which is, where is the virus today? Where is it going to be tomorrow? I want forecast, I want the weather forecast, and I want us to be held accountable for those forecasts and their accuracy. And I'll this is my last slide before we go to discussion with Dimitri, Sherry. So I think, to the extent we can build technologies that are multi-purpose that we can use for COVID, but also going to help us beyond, I think this is what we should focus on. So this antibody detection technology, the dried blood spots, can help us with a wide variety of pathogens. These are some of them are obviously common in the US, including where in the northern states, but there are also potential outbreaks in more tropical places, warmer places. As climate changes, you'd expect, in fact, we are seeing that the geography of these diseases change, and we should, of course, expect new coronaviruses to appear, and we have to be extremely concerned about that. This is not the first coronavirus, so why should it be the last? And this is not the most deadly combination we could imagine of infectiousness and differential fatality. So I think we should really put a lot of effort and money, honestly, into those detection systems. And I think we should really have in our minds that we, as a primary goal, never, ever again to shut down our economies. And that was just, it was a horrible thing to do. It was, I think, arguably justified given the alternatives at that moment. But there are much better alternatives, and there are other countries around the world that have organized their healthcare surveillance and systems and their policy levers differently, who avoided having to shut down their economies fully. And I think we need to take that on as a top priority in this country. So never again is a good thing to say, but let's build the infrastructure that makes that a feasible or even obvious thing to principle for policy. And I think I actually made these points the last set of points again. You know, when you believe that severe weather is coming, do you just look outside and judge which way the wind's blowing and the darkness of the sky, or do you go and look at the data, whoever your preferred data set is, or the trusted advisors you have, be that the Weather Channel or some newspaper or anybody else, and see what those models are predicting, and then of course make up your own mind. Do you really want to drive your car right now? Is the snow imminent? What will happen to the road surface? Should your children go to school today? Will you be able to get them home safely? Those are decisions that we all have to make individually, and I think the government should not make those decisions for us. I think there are collective responsibilities, such as whether or not a school system opens, and those decisions need to be made by the responsible local officials, who are therefore, of course, held accountable. But we also need to empower ourselves. We need to empower ourselves as individuals, as Americans, as citizens of the world, to be able to decide for ourselves what's dangerous and what's not dangerous, and to act on that basis.
I want to thank you both. That was fabulous and fascinating. We've had lots of wonderful comments and lots of good questions. But I really want to give you, to start out, the opportunity to ask each other questions and to talk amongst yourselves, because we have good questions from the audience and I have questions, but I would like to have you guys interact, and I'll interject when it makes sense. So who would like to start?
I have a question/comment. Can you hear me?
Yes.
It's not a foregone conclusion. I have looked into the availability of serology data for enhancing the Delta model I have presented. And I found the following complication. The quality of data that we have today on serology is not high. In fact, they are not randomized data, so as a result, they have significant bias. They have significant holes. In other words, I have looked into serology data for various states. In fact, out of all the states that have serology data, the only state that I have found to have reasonably complete is Florida. Every other of the states do not have. There are cities that have reasonably accurate serology data, but while I believe it's important, I agree with that, but just to caution that the current situation with the data in this space is not good. So as a result, it's very hard to put it in models. It's actually harmful. We put a model with serology data, it behaved worse because the quality was not high. So.
Well, Dimitri, I'm going to quote you on that from now on, because that's exactly the point I'm trying to make to people, which is we need to build better, more accurate data. I think that's about two things. I think it's about the technology of the astrology assay itself, by the way. So some of the assays that were used early in the pandemic, some of the ones that got FDA approval, to be honest, were not suitable and not high enough quality. So that is a fixed problem, although you have to look at the assay being used in particular labs in particular places. The second point, though, I think you're making is super important, and it'd be great to get your eyes on this too, which is as we roll out better, cheaper serology, let's think very carefully about sample design to try and get the most information that could be useful already for people like yourself who are doing the forecasts, right? So let's think about ideally we would have as many people as possible monitoring their own blood over time, but it takes a while to get there. So let's think about what we need and where we need it, and you and I can continue to discuss that. And we can, we're proposing to lots of people to get on board with testing for large factories, for example, for nursing homes, to help protect school systems. So let's think about sample design and how to get the best signal from the astrology that we're going to bring online.
I'm with you on that. I also think an interesting, a useful thing to do for prediction is to truly do randomized testing for antibodies. There has been tests, and there has been, as perhaps know, some controversy with the serologists that are done in California, and Stanford was involved. If you have randomized testing, you can actually make very accurate, much more accurate predictions. You are going further than randomized. You're talking about much broadly in the population, which I think is going to be helpful. I agree on that. But even limited, truly randomized testing can actually help us in understanding where the disease is going significantly. I have.
Yeah. And to be fair, I mean, there are some people doing that, and I'll send you some references. There's a team at Johns Hopkins that's pushing for broader surveillance. I think the more eyes on that, the sooner the better. Dimitri, including, what particularly, I think you need signal, right? You need an accurate signal, and you need to understand the source of any noise or distortion. So I completely agree, and that's what I mean by thinking about how to scale this up and get more information sooner. I think if we have some well-designed, randomized samples, then that will be very helpful to you and other modelers and other forecasters. So we'll take that on as a goal.
Yep. Okay.
Simon, do you have any questions for Dimitri? I have a few questions if you don't.
Well, I think Dimitri, this just to push you on the weather forecasting, and what would it take to get your kind of forecast in front of people just like, so on my phone, before I go to any city, I look up what the weather is, right? It's very easy, very transparent. How far are we? What are we missing in terms of something that this is actionable and that people want to look at every day? It's like, that's what the weather is. I better take an umbrella. I think we're looking for that level of sort of impact on granular decision making. What do you think we need?
So one of our efforts through the website was to do that at the country and state levels. If you want to do it at the city level, this requires more granular data. In some cases, we have been successful, like we have at requests for particular cities around the world, we have been asked and delivered forecasts. But I would say the only thing that is missing is data, incidence data, at the level of a city, at the level of the environment you are. So we have definitely done it for over 1,000 entities, all states in India, all states in Peru, all states, about 50, we can do it, but the data is of dubious quality sometimes. So as a result, but if we have an environment that we can collect data from all parts of the world, which we have done, because we have an ongoing website, it's updated daily, about 15,000 people take a look at it on a daily basis. I think that's the way to do it, which was the initial intention. I mean, we have made some success. The fact that CDC is using it is obviously helpful. It added some traffic, but that's what is needed, I would say. And why the publicity, an event like that would help, and so forth.
Yeah, look, I think, Dimitri, I think it's amazing work, and I do agree you're making fantastic progress. I just feel, though, that, for example, in Arizona, I mean, not to pick on Arizona whatsoever, but just because it's in the news headlines.
Yes.
If people understood there should be somehow we're missing like some self-breaking in the system, right? So that if people in Arizona understood the risks around them, I mean, at least the risks as I see them, I think as you see them, they would be backing off more, and that would naturally limit the spread of the infection more than we're currently seeing. I mean, same thing applies, by the way, to young people going out to whatever activities it is where they're crowded and there's a lot of people together. I mean, somebody was telling me about bars in Baltimore just over the weekend. Let's just give one anecdote, right? The same point. People are missing this connection between if the infection spreads between us, we're young people, that's fine, okay, but how do you think it gets in nursing homes? Right, it goes between the young people. It goes into the communities where the low-income nursing home workers work. They get it on the bus on the way to work. They carry it into the nursing home, and people die. I don't understand. I really do not understand why smart, rational Americans or international people don't get it. I mean, we have MIT students. Just to put our cards on the table, I don't think I'm giving any secrets away here. We have MIT students. When we survey them and say, "Will you wear masks on campus, outside the dorm, moving around and going into buildings?" They say no. I say, what is that about, right? Seriously, guys, we have to have this conversation at the national level, at the intellectual level, which is, if you allow yourself to get infected, that's your business. But it's not about that. This is about smoking in front of your children, right? You kill people with secondhand smoke. That's the fact, right? You kill people by becoming infected because you spread that through the community and it comes into nursing homes. So,
Simon, I agree. But unfortunately, rationality is not a characteristic of all of humanity. Just to remind you, we recently have an event, a political event in which the vast majority of the population in an indoor space did not wear masks. So people don't act rationally. I mean, I have to admit, I have given up on, complete human rationality. So,
Okay.
And I saw a comment. I just saw a comment that just to bring up a comment that said, "How can you influence people? Do you really think you're going to influence people by trying to protect other people?" That's what.
So, guys, look, first of all, I'm an economist, and secondly, I was chief economist of the IMF, so you can't get ahead of me on being cynical. Okay, I'm way ahead of you. But let me say this: youth smoking, Dimitri, used to be a big problem. I think it was about 30% prevalence youth smoking 20 years ago. Now it's down to about 10%. Massive public health campaign. Hammer them on the messages. Make it simple. Go full at it. Is everyone rational, sufficiently rational, does rational prevail entirely? No, you're absolutely right. But if we get on the message and we hit it really hard and we put sufficient focus and resources in it, is there a failure of leadership at the top in this country? Okay, well that one's. I don't think we have to do a poll on that. Right, but why are we waiting for the leadership? Why do we need the White House to lead us on this? I don't get it. This is civil society. This is MIT. This is knowledge. I believe, Dimitri, totally that we are going to set standards of norms, of behavior at Sloan, but we won't do it. You and I will not do it. The students will do it for themselves. There are 4 MDs in the program, the 2-year MBA program, and I'm suggesting that they be among the leaders in helping us think about the world, infections, deaths, and how they choose and they recommend that their colleagues live in that world. And I think everyone on this call should do the same. I think it's individual responsibility, it's protecting your families, and it's stepping up to protect people in the nursing homes. I am tired, Sherry, very, very tired of politicians, business people, and academics saying to me, "Thank you, Simon, for working in nursing homes over the past 2 months." I mean, seriously, guys, this is a collective responsibility. We either act together in the way we're talking about right now, or these people will die. It's your decision.
But that's so culturally. I mean, how do you? I mean, since it's a global pandemic, and like you said, in Korea, and in Asia, the results are different, or the compliance. But in the United States, you see it different across the country, right? There's compliance in some spots, and there's not in others, and it's cultural. And I just happened to watch a YouTube or a CNN video the other night with people screaming about wearing masks, that it was awful. So anyway, curious your comments on the culture.
Well, as an immigrant, I mean, Dimitri's also an immigrant, so I don't know his perspective, but as an immigrant, Sherry, what I love about America is the vibrancy of the democracy and the fact we can have these discussions and the fact we go at it. And so let's go at it. Let's go at it through ILP. My next event in half an hour is with some other group, and let's hit this message and let's put data before them. Let's show them Dimitri's models. Let's track those predictions, right? Eventually, I think you persuade some people. Do you persuade everyone? No. Is it a good use of our time as faculty at MIT? I think so. Under these circumstances.
I don't mean to sound. I'm a hick, so I don't mean to sound. I don't know what you want to call it, but I mean, a lot of people wouldn't be able to interpret Dimitri's model, right? I mean, that's something that you and I can do. And so how do you put it in terms that make it understandable instead of showing graphs?
I want Dimitri's forecast, or someone's, but let's go for Dimitri, on my iPhone, every day, people looking at it, keep it simple and explain it and convince people why they need to look at it. So I agree there's some work to be done, Sherry, but I think we know what the tasks are.
Simon, if you go to COVID-IO on your iPhone, you will see it in your iPhone. I mean, it is possible. I mean, it is. And
I was proposing for Apple to put it in their baseline, software that no one can opt out of, Dimitri. But yes, we'll get it on. We'll get it on our phones, absolutely.
Okay, maybe we ask the audience to help us, Sherry, for questions.
Yes, I like this question because we have a corporate audience. But what does a responsible corporation do to try to get back? I mean, what are your ideas on how you could go back to work and be responsible in September? What do you do? Is it contact tracing, which I personally have a lot of skepticism against, but I'll let you guys comment.
I can tell you, I mean, I'm involved at the moment with a large bank abroad, about 23,000 people. I've been advising them. The key aspect, in my opinion, is testing. I do believe serology might help, but testing is fast testing that you can get the test in minutes, not in days, and therefore you can quarantine fast and so forth. I also think this is also relevant at MIT. We are opening the campus very soon. We better have frequent testing, because if you leave it, otherwise there might be an undetected event. Then there would be the spread would be instant. So I think testing is particularly relevant in my view. Contact tracing, for it to be useful, in my view, it has to be widely utilized. I have some doubts in Western societies whether that could be effective.
I got three things, Barry. Okay. First of all, masks. The masks are not magic, but they make an enormous difference. You'll see evidence coming out from the hospitals. I think it's in process, showing that masks really are effective when worn properly in reducing transmission, not to zero, but reducing it dramatically. Second thing is ventilation. You have to assess all your spaces, and we know it's about airflow, and we know it's about, don't sit downwind of people relative to the air conditioning, right? Figure that one out. And there's a bunch of other pieces that Lydia Baraiba from MIT will be coming out with, and we'll be helping to share through your network and more broadly. Very concrete heuristic advice. And the third thing is definitely testing. And I think what's really striking to me, Dimitri, is that there's a sort of madness out there, which is people say, I've got to test. They say, okay, why are you testing? What's the strategy of testing? What are you seeking to achieve with testing? And of course, there's a variety of budgets out there. And, if you can make it work logistically to test all your people twice a week, fine. I'm not going to stand in your way. I would tell you that compliance is going to be difficult, okay, particularly in low prevalence situations. High frequency virus testing is not the general recommendation, but you can do it if you want. You need to back it up with serology, because in one of my missing slides, the most brilliant slide that I didn't show you, Sherry, explains why.
We will share them all, Simon.
Everyone look at that afterwards. That's fine. But you need a fail-safe, because the virus testing, even at high frequency, is going to miss some serious outbreaks. Okay, that's just that's a standard fact in public health. So now the good news is there will be some technology coming along for, I believe, rapid antigen testing. There's one test on the market right now. It's hard to get your hands on it. There'll be others, I think, including a company called E25 Bio, which is an MIT spin-out. I have very high hopes for them. You can talk to them directly, everyone. And I think there may also be some rapid PCR type tests or isothermal tests that don't have the same amplification technology that you can do on the spot. And there may even be some point of care tests by the end of the year, which would be, to Dimitri's point, you could test everyone who's coming into the office every day, or every nursing home worker every shift, and that would be immensely helpful, right? Particularly in these situations where highly vulnerable people are exposed, and once it gets into the nursing home, it's extremely difficult to stop the outbreak.
So I have a question regarding, a lot of the predictions I hear about will probably have therapeutics that will drastically, I know there's one out there now that is 30%, the efficacy is 30% about, reducing the death rate. Once the therapeutic, there's predictions that therapeutics will be in place before vaccines, and that once those are in place and they very much offset the risk of death, that people will go back to normal. Is that what you predict? And what is the risk there of things like mutations and other pandemics coming beyond this?
My own sense is that without a vaccine, going back to normal with very partial therapeutics, I don't think it will happen. So
it will happen.
I don't think, a vaccine is what I think. Even a partial vaccine will go a long way. For the flu, for example, we have a partial vaccine. It's not a certainty every season that it will capture the mutations. So yet we function, society functions. I think therapeutics alone, as incomplete as they are, I doubt that they will allow us to go back to normal. Another comment I have about therapeutics is something I'm currently doing. I believe therapeutics can be personalized. I believe this generally in medicine, but specifically, we have been some experiments with three major drugs that have had some success. And we see that for certain people, they work fantastically well. For some others, they don't work at all. So, which is not surprising given what I have found elsewhere in medicine. But so I do believe that personalization and we can improve things, but for back to normal, I believe a vaccine is necessary. That's my opinion.
Yeah, Sherry, I'm not an immunologist. I don't even play one on TV. But what I do talk to them a lot, and I think what they say is what Dimitri just said, which is you'll get something. It may help some people. It's not going to be the game changer. Vaccines, we hope, will be the game changer. But let's face it, that's not 100% bet either for the reasons Dimitri just outlined. So I think building defensive systems now and then thinking about continuing them to defend the workplace, defend the school system, defend our college campuses, defend our families and friends. I think those are the smart investments right now.
Okay. I have a question, it made me think a lot about the whole ethics question. I know, Dimitri, especially with your calculator, how do you make, I know I saw some guidance in Boston, but how do you make decisions about who what are the ethics around that very difficult question when you put somebody at risk?
But so first of all,
especially with the ethnic.
Let's think about the situation in Italy, or what I anticipate the situation might be in Arizona in a couple of weeks if they don't decrease the spread of the epidemic. But in the middle of the epidemic in Italy, we have been collaborating with, they had decisions. They were life and death decisions, not because they wanted to, because they had no other option. So I believe data and analytics can, in this case, at least can give you some much more objective. My objective to make this data transparent, clear, and so forth, and let the people who make these decisions make decisions based on knowledge and data, as opposed to intuition or who you know and so forth. There are important decisions to be made. In fact, significant ethical decisions that I'm not addressing, but I would put emphasis on preserving human life as the value of what I do. And I leave it to the doctors, the experts. They have to use this technology to do it in a way that is objectively appropriate.
Simon, any comment on that?
I agree with Dimitri. I mean, we're not doctors, but we have tools and we have experience that we can bring to bear. And I'm just full of admiration for everyone who's really on the front lines and really helping people. And I think that by listening carefully to what they need and helping them identify what we can add and when we can add it, I think that's a contribution. I agree with Dimitri. I mean, this is a moment when I feel that MIT and the Sloan School and others actually have a responsibility to step up and bring what we know to bear in an appropriate manner. So,
So my last question is, thank you. We run out of time. I've seen a lot of, I want to ask you one last question and how you could do this together or your thoughts. I've seen a lot of resonance with the whole Waze idea. I mean, I have a lot of doubts on the contact tracing as people downloading it and getting saturation enough, but so how could you work together to make that so that you had an app on your phone that you could look and say, oh, this is a hot spot, I won't go, real time in a much more granular fashion than we can now look at, what's going on where. I think that's been a private way to remotely kind of decide how you live your life.
I had some discussions already with a professor at the Media Lab that has his group has developed a successful tracing application. There are others. To me, though, for this to be successful at the global level, the level of use should be high enough. Because, if you have, let's say, take at MIT, only, let's say, 30% of the population use contact tracing and 70%, it's not that effective. I mean, I'm sorry to say that you need a certain threshold above which contact tracing could be penetration of the population for this to be particularly helpful. So contact tracing can be useful. I'm not saying it is not, but I would think measures like the ones Simon mentioned, masks, testing, looking at the buildings, the ventilation, are perhaps possibly even more effective methods of doing it. Yeah. That's my 2 cents on the matter.
Yeah, I share your skepticism of contact tracing, Sherry. It's okay to try. It'll get quickly overwhelmed in this situation. Dimitri's right on his reservations too. I think the Waze idea is different. The Waze idea is, what's traffic right now, right? What's going on around me, which is data. And then you have a predictive model, which is what Dimitri's in the business of doing, which says, okay, which route should I take? If I need to go to school or I need to go to work, should I go this way or that way? Well, that's partly based on congestion and traffic, right? But think about the pathogens, right? Where do we know the pathogens are as we move around the country or move around the world or even move around our cities? Right? You need data and you need predictive analytics. So I think, I mean, we're obviously not the only two guys working on this, but I think you need both. I think these things are highly complementary, and I think it's the best kind of intellectual, competition and cooperation that we've got, including at MIT. So let's just do more of it, I would say.
I love it. We have to end now. I can't thank you both enough. All the slides and everything will be available on our website as well as the video. I apologize for the technical glitch that we had to the audience and to Simon, but that's the way it works here. So please let us know if you have any questions. Have a great day. Enjoy the summer. And thank you again, Dimitri and Simon.
Thank you, sir.
Thank you.